a 42-year-old female presents with persistent cough, mild hemoptysis, and new-onset severe headaches. I am showing you her axial chest computed tomography scan and a contrast-enhanced brain magnetic resonance imaging scan. Describe the findings.
The axial chest computed tomography scan demonstrates multiple bilateral, well-defined cavitating pulmonary nodules with thick, irregular walls. The contrast-enhanced brain magnetic resonance imaging demonstrates diffuse, linear thickening and abnormal enhancement of the dura mater, consistent with hypertrophic pauci-meningitis.
Based on these imaging findings, what is your differential diagnosis?
The differential diagnosis for multiple cavitating lung nodules combined with hypertrophic pauci-meningitis includes granulomatosis with polyangiitis, tuberculosis, neurosarcoidosis, and IgG4-related disease.
If I tell you the patient has a history of chronic refractory sinusitis, nasal mucosal ulcerations, and a saddle nose deformity, alongside recent hematuria, how does this modify your diagnosis?
This clinical combination of upper airway granulomatous inflammation, lower airway cavitating nodules, renal glomerulonephritis, and hypertrophic pauci-meningitis completes the classic presentation of granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. Other systemic conditions are less likely given this specific clinical triad and laboratory profiles.
What laboratory test is most helpful and specific to confirm this clinical suspicion?
The most helpful and specific laboratory test is the antineutrophil cytoplasmic autoantibody with a cytoplasmic pattern, or CANCA, which targets proteinase 3.
What is the defining clinical difference between the classic systemic form and the limited form of this disease?
The limited form of granulomatosis with polyangiitis is confined to the upper and lower respiratory tracts without renal or neurological involvement, which carries a significantly better prognosis than the classic form.
Describe the key computed tomography angiocentric sign associated with these pulmonary nodules.
The angiocentric feature is the vessel sign or feeding vessel sign, where a pulmonary vessel is seen leading directly into the center or periphery of a nodule, reflecting the underlying vasculitic process.
What is the second most common radiological pattern of pulmonary involvement in this disease, and what does it represent pathologically?
The second most common pattern is focal or diffuse alveolar consolidation, which pathologically represents pulmonary hemorrhage or organizing pneumonia.
Explain the histopathological findings characteristic of a biopsy GPA pulmonary nodule.
Histopathology classically demonstrates a triad of necrotizing granulomatous inflammation, geographic necrosis, and small to medium vessel vasculitis involving both arteries and veins.
State the critical safety warnings and potential life-threatening complications of this disease.
The major life-threatening complications are diffuse alveolar hemorrhage, which presents as rapidly progressive consolidations and hypoxia, and subglottic stenosis causing acute airway obstruction. Additionally, rapid renal deterioration can occur from crescentic glomerulonephritis.
What are the immediate clinical management recommendations for a patient presenting with diffuse alveolar hemorrhage?
If diffuse alveolar hemorrhage is suspected, it is a medical emergency. The patient requires immediate high-dose intravenous methylprednisolone pulse therapy, consideration of plasmapheresis, urgent ICU admission for ventilatory support, and referral to rheumatology and nephrology.